Hello, everyone. Dr. William Davis here. I'd like to talk to you about a topic I think is, while the science has gathered steam, is very underappreciated as a major player in multiple forms of disease, from overweight to type 2 diabetes to neurodegenerative disorders like Parkinson's disease or Alzheimer's dementia, to coronary disease, atrial fibrillation, skin rashes that includes rosacea and psoriasis and eczema, to gastrointestinal conditions, to mental health conditions, depression, anxiety, suicidal thoughts. And that unless you appreciate this phenomenon and take advantage of that knowledge, that you can't have full control, I don't believe, over health, over multiple aspects of health. And so I call this lipopolysaccharide endotoxemia uber risk factor for modern disease, that it plays a role in virtually all modern chronic diseases. Not injury, not infection, but modern chronic disease that you're all familiar with. You all know that the human colon is home to trillions of microbes. That's the natural situation. That's how it's supposed to be. So there's a high density of microbes, about 10 to the 12 microbes per milliliter, the highest in the body of all organs, consisting of a mixture, right, of gram-negatives, gram-positives, aerobic species, anaerobic species, and of course archaea, fungi, viruses, and phages. Now the colon is fairly well equipped to deal with this number of microbes. It's not very penetrable, and it has a two-layer mucus barrier to protect the luminal, the endothelial lining from these microbes. And of course, I remind everybody that the colon drains via the portal venous system. I highlight that because it's the liver that in many cases takes the brunt, takes the blows from this flood of toxic breakdown products from bacteria living in the colon. Now, a neglected area is the small intestine. But let's talk about the microbiomes outside of the colon. So we know that the oral microbiome is second only to the colon in the density of microbes, about 10 to the 11th per milliliter. Not as much as the colon, but still pretty darn dense. And that's an area that really deserves more attention because we're finding, of course, oral microbes in the brains of people with various neurodegenerative disorders like Porphyromonas gingivalis and Fusobacterium nucleatum, as well as fungal species. So that's a topic for another day, of course. As we go down to the stomach, there's a marked drop-off in the density of microbes, likely because of such factors as stomach acid. Only a handful of species are tolerant to stomach acid. And so, no surprise, stomach is kind of thinly populated, but it is populated. But as we enter into the small bowel, first the duodenum, then the jejunum and ileum, there is an increasing density of microbes, not quite as high as the colon, but still quite dense in microbes. Now, the sad truth, if we compare our gastrointestinal microbiome, as well as microbiomes of other body parts, could be airway, could be bladder, could be vagina, could be mouth, we've lost hundreds of microbial species. So in comparisons with hunter-gatherer populations, unexposed to antibiotics, unexposed to herbicides, pesticides, glyphosate, chlorinated drinking water, preservative, other additives in food, they have far more species, hundreds of more species than we do, likely due to our exposure to antibiotics. About 700, more than 700 prescriptions for antibiotics are written every year for every 1,000 Americans. So there's a wild overexposure to antibiotics. That's true also in children. Of course, herbicides, pesticides, specifically glyphosate, which is an antibiotic as well as an herbicide. Preservatives in food like potassium sorbate or sodium benzoate that are antimicrobial. They keep such things as mold from growing in your food, but also are antimicrobial in your gastrointestinal tract when you consume those foods. Emulsifying or mixing agents like polysorbate 80 or carboxymethylcellulose also emulsify the intestinal mucus barrier and thereby shifting microbial composition in the GI tract. Synthetic sweeteners such as aspartame shifts composition of the gastrointestinal microbiome to that approximates that seen in people who are obese or type 2 diabetics. Of course, stomach acid blocking drugs remove the acid barrier to the descent of oral microbes and to the ascent of fecal microbes into the stomach, into the upper small bowel. So the loss of stomach acid, whether it's purposeful, with a PPI, say like Prilosec, or whether it's inadvertent, like autoimmune gastritis or H. pylori infestation, allows microbial infestation of the upper bowel. Non-steroidal anti-inflammatory drugs, widely used for arthritis and other conditions, also causes an increase in intestinal permeability and changes the microbiome composition of the GI tract. So we have lost diversity in the gut and in the small intestine. Now, this has allowed a peculiar phenomenon to occur. The overproliferation, while we've lost important species we would regard as beneficial or favorable, it has allowed the overproliferation of fecal microbes, proteobacteria. So we've lost populations in the colon and to a lesser degree in the small intestine of beneficial microbes like Akkermansia, Mucinophila, Fecalibacterium, main butyrate producer in the GI tract, Clostridia. Clostridia, of course, is a mixed bag. There are bad Clostridia like Clostridia difficile or Clostridium botulinum, causing botulism, but then there are beneficial Clostridia. So I suspect this is going to be separated into different genuses or genera over time because there are beneficial Clostridia like Clostridium butyricum, a butyrate-producing species, Roseburia, Lactospiraceae, Ruminicaceae, Bifidobacteria infantis, Lactobacillus rhodori, Lactobacillus gasseri. It's those two that I've highlighted at the bottom that I'd like to focus primarily on. So these are microbes we've either lost outright or have had marked reductions in their populations in the colon and to some degree in the small intestine. And the loss of those species, those beneficial species that were suppressive over fecal species, mostly Proteobacteria or Enterobacteriaceae, allowed the overgrowth of those species such as E. coli and Klebsiella, Campylobacter, Citrobacter, Salmonella. Those are the gram-negatives. But it also has allowed overgrowth of gram-positives such as Enterococcus, Staphylococcus, Streptococcus. Though the topic for today, I'd like to focus on the overgrowth of gram-negatives. Now, we now know with good evidence, and we're pursuing further studies to better validate this, but we've virtually all modern people have lost the microbe Lactobacillus rhodori. The best evidence tells us about 1 in 25 people still retains rhodori, but it is ubiquitous among hunter-gatherer populations unexposed to antibiotics and all those other factors. It's also ubiquitous in wild mammals, likewise unexposed to those things, yet we have lost, nearly all of us have lost Lactobacillus rhodori. Almost nobody has it anymore. Lactobacillus gasseri, another important microbe that can colonize the small intestine. It's highly variable. There are many people, though, who have lost it completely or have had populations reduced, and we'll talk about why that's so important. And the reason why we've had a reduction in these microbes, these microbial species, mostly in the small intestine as well as colon, is because they're susceptible. Most lactobacillus species are very susceptible to common antibiotics, like amoxicillin or clarithromycin, antibiotics that are handed out quite freely in conventional practice. Well, what makes those two species in particular very important is they have the unique capacity among probiotic-type species to colonize the small intestine. Most species we regard as beneficial cannot colonize the small intestine, but rhodori and gasseri are unique. They have properties that allow them to adhere to the small intestinal mucus and to the epithelial lining, and so they colonize the small bowel when they're present and produce bacteriocins, effective largely in killing gram-negative species. So Lactobacillus rhodori, Lactobacillus gasseri, effective in colonizing the small intestine, where they take up residence and produce bacteriocins that kill invading fecal microbial species of proteobacteria, such as E. coli and Salmonella. And so not having those species, those two species, or having them present at very low numbers, allows the proliferation and colonization of the small bowel by fecal microbes, the E. coli, Klebsiellas, and Campylobacters of the world that take up residence, trillions of them, in the small intestine, where they do not belong. And these microbes, of course, these invading fecal microbes don't live for very long. As you well know, microbes live for a matter of hours, not years, not decades, but hours. And if you have trillions of microbes in the small intestine living and dying rapidly, they release their toxic products, but especially so-called lipopolysaccharide endotoxin. Recall that the small intestine is by design very permeable because that's where you're supposed to absorb such things as vitamins and minerals and fatty acids and amino acids. And so the small intestine, ill-equipped with a single layer mucus barrier, unlike the two-layer mucus barrier of the colon, allows this endotoxin, lipopolysaccharide endotoxin, being released by the death of gram-negative invading species into the bloodstream. And that, of course, is called endotoxemia. Now, I'm going to propose to you that this process of small intestinal bacterial overgrowth, or we say SIBO, S-I-B-O, is the largest non-infectious epidemic in the history of our species on this planet. And we know this from all the studies, several dozen of them, that ask this question: in condition blank, what proportion of participants test positive for SIBO? Usually using hydrogen gas breath testing, sometimes other methods like endoscopic aspirate and DNA analyses of the aspirated fluid, but mostly H2 breath testing because, of course, microbes produce hydrogen gas and we cannot, and measurement of hydrogen gas can be used in using timing of release after ingesting something that microbes convert to hydrogen gas. You can use it as a mapping maneuver. So hydrogen gas detection in the breath is a mapping strategy to tell where in the GI tract microbes are living. That is hydrogen gas producing microbes, because if it's produced rapidly upon ingestion of something, say like lactulose or inulin, you know that microbes must be high up, stomach, duodenum, jejunum, because it takes too long, it takes much longer to get to the colon, where hydrogen gas by fecal microbes is expected and is normal. So hydrogen gas produced too quickly is a way to map where microbes are living in the GI tract, microbes that produce hydrogen gas. Well, let's take various conditions one by one. What about the 60 to 70 million Americans known to have irritable bowel syndrome, IBS? Well, it varies from study to study, but the average is about 31% of those people test positive. Well, that's 18 to 20 million people right there with IBS. How about the 100 million plus Americans with obesity? How many test positive? Once again, varies from study to study, but on average, about 50%. Add another 50 million to the people to the list. How about skin conditions like rosacea, eczema, psoriasis? Well, about 40% will test positive of the 6 million people with those conditions, another 2.4 million. How about type 2 diabetes? Of the 34 million Americans, 40% will test positive, adding another 14 million. Now, of course, there's some overlap. Let's say an obese type 2 diabetic with fatty liver. But you can get the idea. Factor in further neurodegenerative diseases, sleep apnea, restless leg syndrome, autoimmune conditions like lupus or rheumatoid arthritis, depression, anxiety, other mental health conditions, fatty liver. You can start to appreciate we're talking about a huge, overwhelming number of people. I think conservatively estimated over 100 million Americans have SIBO. I actually think it's higher than that, probably more towards 150, 160 million. But we're not talking about a condition that's rare, uncommon. It's a part of the lives and the health, deteriorating health of numerous Americans, probably about half the U.S. population, if we believe these analyses. Here's a review that did a similar kind of analysis, and they came to similar conclusions. You can see that the number of people who test positive for SIBO and the conditions listed: Crohn's disease, 25 to 88%, radiation enteropathy, 26%, ulcerative colitis, 81%, fibromyalgia, 93%, may actually be higher than that, on and on. We're not talking about a condition that's rare. We're talking about a condition that is ubiquitous, is in fact almost the rule in many common health conditions. And if you allow it to smolder, you cannot have control. You can give somebody a biologic, for instance, an intravenous or intramuscular biologic, to block some step in an inflammatory pathway, but you've done nothing for the source of inflammation, for the source of infestation in the small bowel, and endotoxemia. So as I mentioned, the small intestine is permeable because it's supposed to be that way. That's where you absorb nutrients. But when you have trillions of gram negatives, those E. coli and Klebsiella, they're able to enter the bloodstream. So there's a flood, a surge in lipopolysaccharide endotoxemia when this situation emerges. Now, so it's this peculiar this molecule, lipopolysaccharide, that increases 2 to 4-fold in the presence, in the presence of SIBO. So it's not as high as in sepsis. That if, let's say you had urinary sepsis, where E. coli, for instance, enters the bloodstream from the bladder after it ascends into the kidneys, pyelonephritis, and then you have gram-negative sepsis. That's where LPS endotoxemia can be 100-fold or higher. So in this situation, is not as bad as sepsis, so it doesn't kill you immediately. It just takes its toll chronically, this low grade. And by the way, this is probably an underestimation because the assay, the amoebocyte limulus assay to measure LPS is not perfect. It tends to underestimate the magnitude of increased LPS because the method does not recognize all forms of LPS, and so it likely is an underestimation. But nonetheless, when you have this situation of a permeable small intestine infested by trillions of fecal microbes releasing lipopolysaccharide endotoxin, you get the situation of endotoxemia. Pardon me. What else can further increase intestinal permeability in the small bowel and make the situation worse? Well, just the mere presence of gram-negatives in the small intestine further increases an already permeable small intestinal wall. The loss of important species in the colon, but to some degree in the small bowel also, Akkermansia, Faecalibacterium, Clostridium, the main butyrate producers, because recall that butyric acid enhances the mucus barrier, enhances the intestinal cellular barrier, and when you lose these or they're reduced in populations, it allows an increase in intestinal permeability, penetrability of the small intestine. The loss of those two species I highlighted, Lactobacillus reuteri, Lactobacillus gasseri, small intestinal colonizers, bacteriocin producers. Anybody who consumes a diet rich in healthy whole grains is thereby exposed to the gliadin protein of wheat. We know with good evidence from people like Dr. Alessio Fasano when he was at University of Maryland, now at Harvard, we know with good evidence that the gliadin protein of wheat, pardon me, the gliadin protein of wheat increases intestinal permeability quite dramatically and is the initiating factor in many, if not most, forms of autoimmune disease. Well, the combination of exposure of the gliadin protein of wheat with endotoxemia is a lethal process. It amplifies disease. So the common advice to cut your fat and saturated fat, eat more healthy whole grains, is lethal advice for metabolic health. Wheat germ agglutinin, something else in wheat and other grains, is a toxic compound. It's completely indigestible, but it's very toxic to the intestinal barrier. It essentially denudes the villi lining the intestinal wall. And then all those additives we talked about, polysorbate 80, carboxymethylcellulose, other mixing or emulsifying agents like carrageenan, and acetylcysteine. I see people using that because they say it promotes glutathione as an antioxidant in the brain, but it's also a potent emulsifying agent. That's why it's used in hospitals to break up mucus plugs in children with cystic fibrosis or people with COPD who have mucus plugs plugging their airways. They're given aerosolized N-acetylcysteine, a potent emulsifying agent. Ironically, polyethylene glycol, Miralax, used as the bowel prep in colonoscopy, prior to colonoscopy, is a very potent emulsifying agent that disrupts the health of the intestinal barrier, disrupts mucus barrier for several days. So we're swimming in a sea of factors that increase intestinal permeability and amplify the severity of endotoxemia that may have been initiated by the overgrowth of fecal microbes in the small intestine. Non-steroidal anti-inflammatory agents make it worse. Lack of omega-3 fatty acids, because omega-3 fatty acids are known to activate intestinal alkaline phosphatase that lines the intestinal wall. that partially deactivates that lipopolysaccharide in the intestinal lumen. Lack of vitamin D, a major player also. Each one of these issues may not be sufficient to generate all these problems, but they all stack up. They all add up to contribute to this epidemic of SIBO and thereby endotoxemia as a driver of chronic disease. And we know this with good evidence ever since Dr. Patrice Candy at Belgium documented, his team documented this idea that endotoxemia, LPS endotoxemia, in this initial study, published in 2007, was a driving factor in obesity and insulin resistance. The list of conditions generated or worsened by endotoxemia has expanded dramatically since the initial documentation of endotoxemia by Candy's work over a decade ago. And we also know that this is important for cardiovascular disease, my world, right? That the higher the insulin level, as in people who are insulin resistant, which is epidemic, at least 2/3 of the US population has insulin resistance and thereby higher levels of fasting insulin. An insulin sensitive person has a fasting insulin level of 1, 2, 3 microunits per liter. A person who is insulin resistant can have fasting insulin levels of 40, 90, 140 microunits. Not 10% worse, not 20%, but 10-fold, 30-fold, 100-fold worse. And that kind of hyperinsulinemia drives hepatic de novo lipogenesis, the process of your liver that converts carbohydrates, like the amylopectin A of wheat and grains, and sugars, including fructose and glucose, to triglycerides. Triglycerides enter the bloodstream packaged in an aqueous soluble particle called very low density lipoproteins, low density because of the high triglyceride content, VLDL particles, that is itself a cause for coronary disease and interacts with LDL particles. Not this fictitious thing called LDL cholesterol, but the actual LDL particles themselves. VLDL, triglyceride enriched LDL particles in triglycerides. There's a series of enzymatic reactions, well documented, that create the small LDL that is the cause for heart disease. And this is driven by hyperinsulinemia, hepatic de novo lipogenesis, and endotoxemia. Recall that the bowels drain via the portal venous system to the liver. So endotoxemia in the portal venous system is a major amplifier of heart disease risk because the liver receives that flood of inflammatory compounds and it amps up. It amplifies the process of liver de novo lipogenesis, conversion of carbohydrates to triglycerides, VLDL, interaction to form small LDL. So we know that lipopolysaccharide is a major activator of multiple pathways in the inflammatory cycle. So just from a cardiovascular risk standpoint, what do we know that gets worse with SIBO and thereby endotoxemia? Well, HDL cholesterol goes down. HDL particles become smaller and less effective in protecting your arteries. Triglycerides go up in parallel with that VLDL. And by the way, you don't have to track VLDL because triglycerides, of the 4 factors reported in a standard cholesterol panel, 2 are ridiculous. Total cholesterol, LDL cholesterol are nonsense. They're completely fictitious. They should have been abandoned decades ago, especially since you can actually measure lipoproteins now. But you don't have to track VLDL because triglycerides, the most neglected number on a conventional lipid panel, perfectly tracks with VLDL. We try to get triglycerides to 60 milligrams per deciliter or less, and that tells us there's very little in the way of VLDL particles to cause coronary disease and to interact with LDL particles. But endotoxemia is a major driver of small LDL particles, the real cause for coronary disease, not LDL cholesterol. Endotoxemia drives higher blood glucose, insulin resistance, and of course higher blood glucose drives glycation. Among the many proteins prone to glycation and thereby acceleration of aging and deterioration are those small LDL particles, 8-fold more glycation prone than large LDL particles. Endotoxemia increases blood pressure. It drives multiple forms of inflammation that you can track with such common measures as C-reactive protein or IL-6 or IL-1 beta or TNF-alpha. It increases the accumulation of visceral fat and obesity. It adds to endothelial dysfunction, that is the abnormal constrictive tendencies of arteries that leads to such things as stroke and heart attack. And it damages the endothelial glycocalyx. So think about that. So we have a situation of SIBO in the small intestine, endotoxemia, damages the glycocalyx of arteries, the finger-like projections that control arterial tone or relaxation. So how do you detect whether this is a factor in you, your clients, your patients, people around you? Well, as I mentioned earlier, you can use hydrogen gas mapping to see where these gram-negative microbes are living. Because if you consume something that these microbes consume, commonly lactulose is used, glucose sometimes used. I use inulin, which I think is smarter because inulin is more widely metabolizable by the species of SIBO, more so than lactulose. And glucose, of course, you metabolize, so it tends to underestimate the frequency of SIBO. So I use 10 grams of inulin powder. So there's a prep in the diet, a diet of 12 to 24 hours of no fibers, no sugars that nourish microbes, and then baseline, next morning, baseline hydrogen gas measurement, and you can use this air device, a consumer device, for about $150, $200, and it registers 0 to 10, the amount of hydrogen gas on your breath. So baseline, let's say it's low, 1.2, consume your 10 grams of inulin or your choice of other provocative factor. And if it goes, let's say, to 9.8 in the first 45 minutes or so, too fast to have reached the colon where hydrogen gas is expected. So if you're producing hydrogen gas, 30 minutes, 45 minutes, an hour, up to 90 minutes, you know you have microbes, fecal microbes, living in your small intestine. So this is one way to test it. The consumer device called AIRE, A-I-R-E, from the company Food Marble. If you want to know how to use this device, I refer you to one of my books, Super Gut Book, because the inventor, Dr. Angus Short, a PhD engineer, didn't fully understand what he invented. He since has shifted course to accommodate this idea that it's a testing device, a mapping device for SIBO. There are other methods. You could do an endoscopic aspirate, but there are flaws with that. One, it's invasive. Most gastroenterologists don't know to look for SIBO, or they submit it for culture. And of course, you all know that culturing wildly underestimates the presence of bacteria. And so not a very good, and most hospitals do not have the capacity for DNA sequencing or other methods to identify most microbes. They simply culture them, looking for pathogens. That will underestimate the number of microbes present in the duodenum or upper jejunum. You can use stool testing, but stool testing is essentially rectal testing, right? We know with good evidence that the microbiome of the ascending colon, for instance, is different from the transverse colon, is different from the descending colon, is different from the rectum, and of course very different from the small bowel, the ileum, and the jejunum. So when you submit a sample for stool testing, you're getting a rectal sample, and SIBO is a diagnosis of location, right? So, but if you do stool testing and you see an overabundance of proteobacteria or enterobacteriaceae, like E. coli, Klebsiella, Salmonella, all those characters, you can suspect, you can't know, but you can suspect that SIBO is present by that rectal sample, but it does not prove that you have SIBO. Unfortunately, plasma lipopolysaccharide is not clinically available, at least not to my knowledge, because of the uncertainties and its tendency to underestimate severity. Maybe it'll become available in the future, but right now it's not available. It's available as a research tool. There is an LPS binding protein assay that is available. It's indirect, so it may be a pretty good test. Serum or stool zonulin, that's a protein that regulates penetrability of the intestines. That may be helpful when it's increased. It suggests there may be an increase in intestinal protein. So it's an indirect way to suggest that there is endotoxemia going on. But if you think you have it, or your client, your patients have it, what do you do about it? Well, the conventional answer is take an antibiotic. Now, I have some real serious concerns about that. If antibiotics are a big part of the reason we're all here with this epidemic, the worst epidemic in the history of our species, is another antibiotic a solution. Now, some people call rifaximin a eubiotic because it may be more selective for pathogens and less selective for beneficial species like lactobacillus. But still, I have some real reservations about, plus it's expensive, and relapses are very common, essentially the rule. There are two, pardon me, there are two herbal antibiotic regimens that I was very skeptical about because these things are concocted very haphazardly. Just a collection of herbal preparations that seem to have antimicrobial properties. But there is one analysis from Johns Hopkins that compared the Candibactin AR plus BR regimen and the FC-Cidal and Disbiocide herbal regimen and compared it to rifaximin retrospectively. And lo and behold, the herbal antibiotics appeared to have superior efficacy. Rifaximin is about 55 to 60% effective. The herbal antibiotics were actually superior, and in fact, the people who failed on rifaximin were successfully treated with the herbal antibiotics. So that is an option for you. But I'm going to propose something I think that's better. Now, we still have a lot of work to do to validate this using something I call SIBO yogurt. What is it? Well, it's combining three microbes, those two that we've lost or are reduced, Lactobacillus reuteri, Lactobacillus gastroi. They colonize the small intestine, produce bacteriocins, effectively killing gram-negatives. I more recently added Bacillus subtilis, several strains of Bacillus subtilis, because Bacillus subtilis doesn't colonize the small intestine but germinates in the small intestine. It's a spore. And when it does that, it produces a broad range of bacteriocins effective in killing both gram-negatives and gram-positives. Because some people with SIBO, while most have gram-negative dominance, Klebsiella, Enterobacter, E. coli, some people do have overproliferation of gram-positives, Staphylococcus, Streptococcus, Enterococcus, and others. And Bacillus subtilis has a broader spectrum of bacteriocin production, including effectiveness against the gram-positives. So we're going to colonize or germinate in the small intestine where SIBO occurs, and we're going to flood them with bacteriocin production. And we're going to use prolonged fermentation to get really high bacterial numbers. So when we perform flow cytometry, for instance, on these yogurts, not yogurt, of course, so don't confuse this with the stuff they sell in store. It looks and smells like yogurt. It is not yogurt. It's nothing like the stuff in stores. But when we quantify the number of microbes in this fermentation process, we use prolonged fermentation. I use 36 hours to allow 12 doublings. For instance, reuteri doubles about every 3 hours or so at human body temperature. So we're going to let it double 12 times, or about 300 billion, billion with a B, microbes per half cup or 120 milliliter serving. And so far, that has, at least anecdotally, worked with about 90% effectiveness. And I believe I could argue it's superior to taking an antibiotic, herbal or conventional, because when you take an antibiotic, it kills things. It doesn't bring back or increase species you'd like. It doesn't increase Faecalibacterium, doesn't increase Akkermansia, doesn't increase Ruminicaceae or Clostridium bactericum. When you restore beneficial microbes, particularly with the added strategies I'll mention in a moment, you get the proliferation of those beneficial species. So I'm going to propose to you that this unique strategy of making SIBO yogurt is a superior strategy. Now, we need to perform the clinical trial to validate this. I'm debating how we do that. We can't have people making their own yogurt. It's too variable. We either have to have a centralized kitchen, make it for people, for participants, and give it to them, or we encapsulate the microbe. The difficulty with that, we don't know the dose of microbe. If we're getting 300 billion or so total microbes in the SIBO yogurt, do we really need 300 billion in a capsule form, which is very expensive, by the way? But know that this anecdotal experience, based simply on logic, not yet validated. Now, if I told you the solution that I'm proposing involves surgical resection of the small intestine, you should say, well, you better be damn confident about that. But what if I told you the solution is something that looks and smells like yogurt that you make in the comfort of your kitchen, and if you've been following my conversations at all, we know that the restoration of Lactobacillus reuteri specifically has other benefits, smoothing of the skin from an increase in dermal collagen, a restoration of youthful musculature, major effect, by the way. In elderly males, a 50% rise in testosterone. In elderly females, restoration of vaginal moisture and sensation. All the effects of oxytocin, the hormone oxytocin, the hormone of love and empathy, also the hormone of body composition, the reduction of abdominal visceral fat, the restoration of muscle, as I mentioned, increase in generosity, increase in empathy, increase the intensity of love and affection from people close to you, increased acceptance of the opinions of other people. So if it's easy to make, you make it in your kitchen, and essentially provides all these dramatic benefits, what would stop you? Even though we haven't yet performed the validating clinical trial, that we will do. Now, there are other things you can do to further reduce SIBO and endotoxemia. We take efforts to cultivate butyrogenic species, that is butyrate-producing species. That's doing things like getting prebiotic fibers like inulin, fructooligosaccharides, pectin, galacto-oligosaccharides from root vegetables. You can get commercial powders like that, onions, garlic, shallots, other root vegetables. Consuming fermented foods, because fermented foods like kimchi, kefir, sauerkraut has species like Pediococcus pentasaceus and Lactobacillus plantarum that also reduce lipopolysaccharide endotoxemia. I have a simple, this is anecdotal, I have a simple recipe for what I call clove green tea. It's you boil whole cloves, that mobilizes the eugenol, essential oil from the cloves that thickens the mucus barrier, at least temporarily. We put a green tea bag, or whatever method you have for making green tea, because the epigallocatechin and other catechins in green tea cross-link the mucin proteins in the mucus barrier, converting it from semi-liquid to semi-gel, at least temporarily, and we add some inulin to the tea because inulin blooms those butyrogenic species. And this has been very soothing for people who are just embarking on this process of trying to combat their SIBO and endotoxemia. We sip it throughout the day. So 10 minutes of boiling the cloves, add a green tea bag, let it steep for a few minutes, add a teaspoon or two of inulin, let it cool a little bit, sip throughout the day. It's been surprisingly effective on reducing the phenomenon of endotoxemia. And then very common things, omega-3 fatty acids, because it disables the intestinal alkaline phosphatase that helps disable lipopolysaccharide in the intestinal lumen, and vitamin D that's helpful for the intestinal immune barrier. And so these are tools for dealing with what I think is one of the worst epidemics in the history of our species. Not talked about enough, because it underlies virtually all the diseases you see around you. So if all you do is block a pathway with a biologic or introduce an anti-inflammatory drug like ibuprofen or naproxen, or do something really dumb like take a statin cholesterol drug to reduce this fictitious biomarker, you've not addressed the root cause of those diseases. And now you know there are methods to reduce the severity of endotoxemia quite nicely using very benign strategies.